Welcome. I am so excited for today's webinar. I'm here with Dr. Eric Storch, who is a legend in my field of OCD, and I'm just really excited to be talking. So Dr. Eric Storch, he's a professor and chair in the Department of Psychiatry Behavioral Sciences at Baylor College of Medicine. He serves as vice chair and head of psychology and co-directs the Obsessive-Compulsive and Related Disorders program at BCM. Dr. Storch specializes in the nature and treatment of childhood and adult obsessive-compulsive disorder, anxiety disorders, PTSD, and anxiety among youth with autism. Among his many accomplishments are 850 published articles, and chapters, 24 books, multiple federal grants, and his specialty is in treatment efficacy. So I am beyond excited for this talk and to learn a little bit more from Dr. Storch about treatment-resistant OCD. So welcome.
Yeah, thanks. Thanks. You did leave out that I know a host of dad jokes, some of which are actually good and may not qualify as dad jokes, but it's really great to be here. Thanks.
Well, feel free to intermingle the dad jokes.
Yeah.
We, in the OCD community, we know that a good sense of humor is incredibly important when we're talking about this topic. So I would want to start with, what are some of the forms of treatment resistance that you most commonly see at your center?
hmm You know, I think we have a pretty neat group here at Baylor, and so with some of my dear colleagues, Dr. Wayne Goodman, Samir Seth, Andy Weiss, Amanda Paler, like we see sort of this full spectrum of people. So, those that are coming in brand new, haven't engaged with intervention, to the point where we have others who are receiving things like deep brain stimulation. Now, the different types of sort of treatment resistance, if you will, can be a variety of things. It can range from the first, which is just sort of not having found the right, match or partner. And I think of that sort of along the lines of, when you find that kind of partner that you want to spend the rest of your life with, and all those other times you dated just didn't work. It's like that. You just need to have the right time, the right place, so on. And then we have other folks that just haven't gotten either completely better, although maybe they improved. We have a small fraction of people who haven't gotten better with other interventions. And then we have a very small cohort of folks who really have struggled with everything under the sun. Fortunately, our first line treatments work really well, especially when people fully engage with them. And so it's a minority of individuals, but the biggest thing I say is there's always hope. There's always something that we can try, we can do. So I never want anyone to feel like they should give up.
Absolutely. And I just want to emphasize something that you just said. ERP and our frontline interventions do work. They work a lot better and more impressively than other interventions in therapy, I think, in my personal opinion. So I don't want a webinar that is focused on treatment resistance to dissuade anyone from doing the first line treatment, which is exposure response prevention.
Mhm. Yep, couldn't agree more. And one of the things that's really unique about OCD is the consistency with which we see treatment outcome with exposure response prevention. Every single study, we're talking 3 or 4 dozen studies here among adults and kids, well-controlled, millions of dollars to do, has found essentially the exact same result, which is between 70 and 80% of people get a really meaningful response. That tells you something, that consistency. Now, we got to help sort out, that 25% of folks that aren't doing as well. And I think, we'll talk more about that, of course.
Absolutely. And I tell my clients, because I'm a lived person with OCD, and I do share that I would not be able to run an OCD center if it was anything less than spectacularly consistent positive outcomes. So I just want to share that. Another plug for just the the gold standard treatment of ERP. But in those cases, when a client has been engaged, because that's, a big if, and also ERP has been correctly, utilized, what are the modifications that your team needs to do on ERP for treatment resistance?
hmm I think one of the first ones is sort of how we started things off. Like, it's being a person, and this is one I know you're good at. It, our field of therapists sometimes aren't like they're not the ones that you want to grab a beer with.
Mm.
And so I mean, look at our sale. Hey, pay me, or in my case, pay Baylor some money. And then I'm going to have you gradually, systematically sort of push back on these fears. What a bad sale. So a part of it is that relationship, first and foremost. The
Mhm.
second part is keeping people focused front and center on why they're doing what they're doing.
Mhm.
And then I think there are other aspects. One of the approaches that we use either at Baylor or with other, great colleagues in Houston or in the community is thinking about different forms of more intensive based intervention. Now, I'd make the argument that all treatment might, you know, it should be intervention, should be intensive, whether it's a few times a week, a few hours a day, a few times a week, whatever. Um, but we have soccer practice, we have kids, whatever. We can't do it. But being able to have a concentrated course of treatment makes a huge difference.
Yes.
Now, sometimes we need to think about other options. So pharmacotherapy can be helpful. When things haven't worked as effectively with behavioral treatment, whether it's reducing levels of distress or sort of tenderizing a belief system that's more refractory. And then I think we have different options from there, which of course can range from other types of psychotherapy, for example, an acceptance-based approach, which I think doesn't really have data looking at any sort of treatment augmentation or addressing treatment resistance. Or we could think about other types of neuromodulation. So TMS has a limited evidence base with effects that are in general pretty modest, with a high sort of lift in terms of intensity of service. And then one of the works we do is focus on deep brain stimulation. Now this is for a tiny fraction of folks who are adults who have failed everything under the sun.
Mm.
And what's been neat about this, and something that we've studied, is that about 2/3 of folks who have failed everything get a lot of benefit from this. Not a little bit, a lot. And of course, it's invasive. So I think at this point, maybe somewhere in the way of 300 to 400 cases in the world have been done. Uh, but the available data are really impressive. And it's the same exact surgery as something like Parkinson's, where you're trying to target the areas of the brain that are implicated in OCD. And we think are maybe a little bit more out of control and folks that just haven't responded to some of these first line treatments like exposure therapy.
Interesting. I have so much to learn about deep brain stimulation. Can you give a case example of a breakthrough moment, maybe involving deep brain stimulation, but a breakthrough moment for an otherwise treatment-resistant case?
Yeah, I think to give a non-DBS example, just because that's the norm. Um, there was one person that I recall in particular where we were really sort of inching into the cold pool, so to speak. But the way that we were going at this was with sort of the adage of a book my parents used to read to me, which is going on a bear hunt. Can't
Yeah.
go around the fear, can't go under it, can't go over it. You got to go through it. And we just want to take small steps towards it. But as we do so, we learn is what we think it was going to happen or predict what happened, does it happen? And I
Mm.
think that element of reinforcing that the prediction was actually completely off gave the person a bit of power to try a little bit more and try a little bit more. Concurrent to that, in that case, in every case, you got to be in the trenches. And so, if we're sitting there worried about someone who's afraid of harming someone on impulse, well, of course they wouldn't. Um, I'm right there with them. That knife might be against my throat. Or one time, it was a parent who was afraid of killing a baby. And I took my baby, who's now 9, in and said, "Here you go, kill her." I have 3. I mean, honestly, I still have 2. That's plenty. Um, and nothing happened. And so I think that was a real moment where you had someone jump off the cliff and realize that there was a parachute, that this just was sort of one of those nightmares that when you wake up, you realize isn't real.
Yes. And so for those of our listeners who are not in on the OCD strategies, Dr. Storch just used a very classic one. So for someone who's afraid of stabbing, we would have them hold a knife up to our throat. And the point of these kind of almost comedic interventions is to show them, I'm not afraid of you harming me. I'm not afraid of you harming my baby. Look at how flippantly I offer up my baby to you. And those just that moment alone, I bet was a breakthrough for that client.
hmm it was, and I think that's you point out sort of this paradox of OCD, the neurotic paradox, which is, folks with OCD are the last people in the world that would ever do anything like this.
Mhm.
But when your mind's saying danger, 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 and you have this great moral sense, you listen to it, and then when you listen to it, and the thing that wasn't going to happen doesn't happen, that neurotic paradox keeps cycling around. And so all we do in therapy, whether it's someone who's brand new to it or someone that's really struggled with treatments in the past, is we have them engage with the thing that makes them afraid in a more direct fashion, but in a slow, gradual, collaborative way that gets them back to the life they want to lead. Um, and I think keeping everything front and center on why are we doing this? What do we hope to learn? And what do you get out of it? Like, does this allow you to be with kids that you love? Does it allow you to play soccer? I like soccer. You know, that's what we want to keep moving, or keep front and center as we go through all treatment.
Absolutely. And I just wanted to highlight a metaphor that you use that's also from the OCD world, which is the idea of the cold pool. We explain to our clients that sometimes exposure therapy is like jumping into a cold pool. It feels horrible. It feels like freezing at first, but systematic desensitization happens in that pool and in therapy, which is that your brain gets accustomed to whatever that, jarring sensation was, and eventually you're able to settle into, the new normal.
Mhm.
So thank you so much. I I am curious, and this I'm going to say as a clinician, I guess at this point I should consider myself, a senior or quite senior OCD clinician, but I have a team of about 8 junior clinicians that I supervise, and I'm curious, what are the most common missteps that you see the less experienced OCD clinicians make,
Yeah.
and specifically with treatment-resistant clients?
Mhm. I think one of them, great question. So I think okay, so let's go therapeutic and let's go interpersonal.
Yeah.
I think therapeutic, one is that they fail to engage in treatment in a robust fashion. So here's an example. I tell this story a lot because I think it's hysterical. I don't like Phil Collins, the singer. I don't see Phil on here. If you're related, I apologize. But I once got a massage right after the pandemic was sort of ending,
Mhm.
Father's Day, and the masseuse played like an hour of Phil Collins songs. I'll give Phil maybe has 2 solid ones, maybe like one and a half. Um, and the whole time, like I find it hysterical because whenever there's something silly like that going on, I'm just in my mind thinking like I can't wait to be, talking to someone like telling the story. Like, thank God this happened to me. And and then he takes a phone call in between, like in the middle of the massage. I'm like, dude, like rub my feet. Now here's the point. Um, I went to him for a unit of service, which was rub my feet and my back. And And instead, he diluted it. He diluted it with this background noise, with taking a break. And so that's, oh, and you could take it a step further. He wasn't, like really rubbing at my feet. Like, that's where I want you to go, buddy. So the intervention was the intervention, but it was a less potent dose of that. That's one of the biggest mistakes. So if we think of exposure as the most important treatment element, which we actually empirically know it is, that the problem with that is that, you know what, if someone gives a less effective dose of it, well, we get a less effective treatment.
Yes.
Or, you spend too much time talking about the week. That's nice. And it doesn't necessarily help OCD. And so I'm all about my team staying focused. You might have problems with, your friend group. Okay, let's get you another therapist. Here's what I do. It's just like if you got diabetes, you don't go to your cardiologist for diabetes care. You stay focused, with your endocrinologist on that treatment.
Mhm.
So I think that's a big one. And then I think on the interpersonal side, just be a human. The most impactful moments I've had in my clinical practice are when I connected with another parent or a person with OCD as a human, saying things like you're not alone, reaching out when they needed support, being there, being beside them, but also like just joking and keeping it light. Because again, who the heck wants to, especially among kids, come hang out with one of us? I mean, you and I, of course, are exceptions, but like other people, maybe. So I think that interpersonal piece is so, so, so critical.
Absolutely. I fully agree. Thank you for sharing those. And I think there's an added challenge here in the outpatient community, is just like you said earlier about dose. We can
Mhm.
rarely get someone to engage in more than once or twice a week in terms of dose. And the drop off between outpatient and sort of an intensive outpatient with Rogers, for example, is a pretty big change. So you go from, seeing your therapist once a week or twice a week to suddenly you're doing it every single day. So I would really advocate for there to be more concentrated treatment in between. But it's hard to deliver.
Yeah, well said, well said.
Mhm.
And sometimes we can task shift. That's one of the areas that we've really tried to push. For example, whether it's a kid vis-a-vis their parent, or it's working with a partner, with the old adage of married men live longer because their wives take care of them, and it's like having a partner there, kind of supporting along the path. But the notion is that the session with any of us is a great vehicle for learning. But boy, if we can teach that person how to, fish, so to speak, they're going to be able to eat forever. That's what we want to do with treatment, is teach this approach to life, where you want to interrogate any sort of fear that you have, and sort of push back to see the validity of it. So
Awesome.
yeah.
Yes, 1000%. And you and I know this, but let's reiterate for our listeners, OCD treatment is time limited. And how do you sort of talk with people about let's push through this and then discharge?
Mhm. I just try to give that education and here's what to expect. And the more you work on this and the more you engage, the better it's going to go.
Yeah.
Now, I also though want to keep it, how do I say this? Keep the phone book open. So
Mhm.
I just wrote a commentary with a colleague, Tara Paris, on this outcome study in kids with OCD where they followed 269 kids
Mhm.
3 years later. Here's the good news. 90% of them were doing great.
Yes.
They start off with CBT. Then
Mhm.
those that needed it could get more CBT or Zoloft. And then again, fast forward 3 years, 90%. That's a great message. Um, and and so what I love about this sort of concept though is, look, bad stuff might happen once in a while. I was a goalkeeper throughout one of the 35 years. I retired a few years ago because everyone was getting younger and I was staying, well, I was getting older. And I've broken my hands 13 times. And you know what? I still can't write. Like if you ask me to do anything other than write my name in a sentence, beyond that, my fingers, so this one in particular that I've broken, I think 4 times, it just starts hurting. So the point is that I could get better, but there's still some residual problems, or I could break it again, or so on. And so what we want to do is have this relationship where the person knows they can reach out if they struggle. Even though most do well, we want to keep that sort of line of communication open. And I think that also helps prevent any sort of relapse over time.
I love that. So keep the phone book open. All right, so I want to transition to a really interesting community. I want to use the term highly dependent adult children, but just once mention that this is traditionally called failure to launch. We are, as a community, trying to move away from that term, very stigmatizing. However, this community is huge. Dr. Leibowitz is studying it currently. He is estimating that the highly dependent adult children is in the millions. And so I would like to ask you, what advice would you give for parents of highly dependent adult children whose main presenting diagnosis is OCD?
hmm Um, well, I think sometimes you have to put some pressure on. Uh, and and I think that's probably the best advice that I can give. But work with someone who understands behavioral principles in helping to really sort of identify what the best approach is with that.
Mhm.
Now, one of the challenges I think is that with this population, there's a level of comfort or lack of discomfort because life's pretty sweet.
Yep.
Honestly, if someone said, "Storch, I'll support you and give you some food and you don't have to do much," uh, doesn't sound too shabby. So some of that, what we need to do is push back on that. Now, at the same time, as a parent myself, I get it. It's really scary when your child's struggling or there's a history where you tried that and it didn't go so well. And so that's where having someone work together with you can really be helpful. Um, Now, Dr. Leibowitz, as you point out, has done such groundbreaking work in trying to target accommodation among younger people. Um, and I think one of the key things we've learned when we've done actually replicated that work and extended it is that our kids with OCD, so minors not a majority age, did less well than our kids with other anxiety disorders when we only did a parent-based approach. So that what that does tell us is that we need the kiddo involved on some level, and that working with the parents can help free up the parents, particularly in terms of their behaviors, although it doesn't erase sort of the anxiety that you feel once you become a parent, and you always have as a parent. Um, but at the other time, kids, young and old, need to be able to have an element of ownership into their own lives. And again, if we make it too easy for them, it becomes really hard to sort of get out of that rut.
Absolutely. And such a cornerstone of OCD treatment is increasing that window of tolerance for distress. And so if you're living a very comfortable life of any sort, your window of tolerance for distress is going to diminish. And I completely see how those two things can get correlated. So same question, but now clinicians. You're giving advice to a clinician working with a highly dependent adult child whose main presenting diagnosis is OCD.
Mhm. So, working with an adult client whose main diagnosis is OCD, I think and sorry, in terms of like how to sort of launch themselves, or
How how clinicians should be working with this population.
got it.
Um, because I think as clinicians, we won't necessarily reach out to the parents of a 22-year-old. However, if the child is like still dependent and living in the home, how would you suggest that clinicians, deal with that?
Mm. You know, so this becomes tricky. And I don't know that there's a necessarily right way. Here's how I think of it. Each person has a choice of engaging in treatment or not. And that may not be consistent with what I think is right, but who cares what I think? So they have to make that choice about what to do. Now, part of what I try to do when I have individuals, young or old, is engage everyone around them. I think
Mm.
mental health has sort of stumbled, and in a way that separates it from other physical illnesses. As we know, mental health, physical health, it's all the same. But if you think about cancer, someone has cancer, you surround them with people to support them. I think that's a really important point about OCD. Now,
Mm.
there's a side benefit of that too, which is as you're doing that, again, the person has to be willing to allow that. Um, you know, they they have a choice of letting that happen or not, but you also build this relationship. So if someone isn't willing to engage, you can also engage the other person in their own options of changing behavior. Now, another thing I'll think a lot about is how to just call things as they are. So if someone's not willing to do the work, um, I don't necessarily believe there's another therapy out there. I think the data haven't shown that at all. I doesn't mean I want to try something, but it's also important to just say, yeah, this isn't working. Um, why don't you call me when you're ready? And then just back away so that they don't have a failed treatment experience.
Mm.
So that's another approach as well.
Interesting. So you would almost advocate for, rather than being stalled in therapy, you know, asking a client to leave therapy until they feel like really, really invested in that work.
Yeah, I think there are instances where that can be appropriate.
Mhm.
The part that I talk a lot about when I do trainings is that, not everyone will have a successful course of treatment in the acute fashion. Again, that study I quoted, 90% of kids were doing great 3 years later. Um, but here's the thing. Doesn't mean there's not hope. It just means pressing on forward doesn't necessarily like make it the right choice. And what I tell folks that I'm teaching is know why. So like if I know why, if someone gets better, I usually know why. It's pretty easy. I did this treatment, they engaged with it, it got better. Um, but if someone doesn't get better, I also want to know why. Now, mostly I want to make sure it's not something I did. I wasn't prepared, I wasn't connected with them, or so on. Now, the knowing why or why not helps you then sort of tweak things. So maybe it is that I have someone and they just don't like my sense of humor, or, the sun shines from my big bald head into their eyes and they don't like that either. Or they don't like talking to some dude. They like someone younger. They want to talk to someone that's not some guy. Okay, I can change that.
Mhm.
But what if it's something like insight or motivation?
Yeah.
Well, insight maybe we can change if we focus on motivational stuff. We try to educate someone. We work with a psychiatrist on different pharmacological approaches. Uh, Motivation, maybe we get really sort of goals-based, motivationally focused. Cool. But I'm always thinking about the mechanisms for why someone gets better or not. And one of these core mechanisms, and then I'm going to shut up, is this aspect of family accommodation. And so we want to target that, whether it's a 7-year-old or a 27-year-old. If that's present, it becomes really difficult to get as good of a response as you want. And so I'm always, again, thinking of the why and then trying to have my intervention poke or pull, or whatever you want to go with, those sort of things.
Awesome. I fully agree. Family accommodation is every age. And in fact, I see a tremendous amount of family accommodation with my adults with OCD, and their family members accommodating the OCD is making it even outside of the highly dependent adult children, with spouses, with their adult children, it is actually making the OCD thrive and making them treatment resistant because the motivation isn't there. So we are out of time. I have one final question that I just want to lob at you. What are your words of wisdom, having worked in OCD, largely in OCD for 25 years? What are your words of advice to a treatment-resistant person with OCD who might be watching this talk?
Yeah. Uh, don't give up hope. There are a host of things out there. Know that there are people, two of which are sitting across from each other on the call, who are working day in and day out to try to discover options to support everyone with OCD. Academic medical centers can be sources of opportunities to engage in kind of cutting edge interventions for those that haven't responded to great ERP, great pharmacotherapy. And sometimes have studies that can help support that. And and don't be afraid to reach out. One of the reasons why I have been blessed really with engaging in the OCD community was simply this random match on my internship that brought me from New York to University of Florida, where my boss is my current boss at Baylor, and this patient population that's beautiful with them to work, colleagues that are so collaborative and engaging, but more importantly, are always there. So there's not a day that goes by where I don't get an email from some random person, and just taking a minute to respond and so on. So don't hesitate to reach out, keep
Mm.
hope alive, keep pushing, and you're not alone.
Oh, wonderful. I love that. And maybe a little shout out on that topic to the IOCDF conference, which happens every year. That's actually where you and I met.
Mhm.
And it's a pretty special space because you rarely have a collaboration of professors, private practice clinicians, and people with lived experience. And sometimes some of us are all three, and to really get together in a very approachable and celebratory way. So looking forward to that. Looking forward to seeing you in Chicago this upcoming summer. And thank you
Absolutely.
so much for being a guest on Let's Talk OCD. I'm so honored.
Oh, are you kidding? Thank you. It's my pleasure, and thank you everyone for taking time on your Friday to be here. Thank you.